Hello again, and it's a pleasure for me to speak to you today on the topic of diabetes and its challenges for 2022 at your 18th meeting. As you know, we are facing a crisis in diabetes across the globe. Diabetes is a huge and growing problem. One of the main jobs or tasks, if you wish, of the IDF is to collect and disseminate the data on the prevalence of diabetes globally every 2 or 3 years. We produce an atlas, and we're very lucky to have as our chairs of the Atlas Committee, Dana Magliani, who's an epidemiologist, very well and distinguished from Melbourne, Australia, and another good friend, Ed Boyko, who's an epidemiologist. You couldn't be much further away in time zones. He's in Seattle, in USA, Northwest USA. The last Diabetes Atlas was published in December last year, 2021. So this is building the evidence to inform a global response to diabetes. It's an authoritative source of evidence on the impact of diabetes across the world. And Diana and Ed have amassed 90 experts in epidemiology from all of the regions of IDF to produce the most up-to-date data on the global prevalence of diabetes. Now, if we look back 2.5 years ago, at the end of 2019, at the IDF meeting was held, some of you will be there, in Busan in South Korea. It was estimated there were around 460 million adults with diabetes, projected to rise to 700 million by 2045. And the predicted rise in the next few years for MENA was said to be 96%, which is very frightening. Now, if you look at what has actually happened, the numbers last year, we published the Atlas in line with our Complications Virtual Congress last December, so about 8 months ago. And it was estimated then that this had risen to around 537 million people across the world with diabetes. And the projected rises were, of course, higher. And each time we underestimate. If you look at the situation now, the Middle East and North Africa, the MENA region where you are, there's approximately 73 million people with diabetes. Here are some data published in recent years from 2 countries in your region, from Egypt, the host of this conference. This was said some years ago, published in 2015, to have the 9th highest prevalence of diabetes globally. And it was stated then that the prevalence of diabetes in Egypt had tripled in the last 2 decades. Increase in type 1 too, not only type 2. The prevalence of diabetes at that time was said to be around 16%. Here's another more recent study from our good friend Abdul Basit, a former regional chair from the MENA region. He published data 5 years ago, or it was actually published 4 years ago, and showing that the prevalence of diabetes in adults in Pakistan is 26%, more than 1 in 4, which is really quite frightening. So to summarize the data from the Atlas published last December, approximately 537 million cases, but now undoubtedly more than 550 million. That's 1 in 10 adults worldwide with diabetes. Of these, 44% are undiagnosed. The prediction for 2045 is now just under 800 million. The global cost of diabetes in 2021 was just really 960, just under 1,000 billion. I'm not an economist, but that might be even a trillion, I don't know. But 966 billion US dollars was the cost, estimated global cost of diabetes in 2021. But these data are really worrying. Look at the rise in global cases of diabetes in just 2 years, 2019 to 2021, 16%. It was also estimated that 6.7 million people died due to, as a consequence, shall we say, of diabetes and its complications, greater than 10% of deaths from all causes. So diabetes is undoubtedly an epidemic of unprecedented magnitude. So I might pose this question to you. Is diabetes the cancer of the 21st century? There are similarities between diabetes and cancer. Screening of high-risk groups we know is very effective in cancer. It's also effective in diabetes. Can we detect people pre-diabetes and prevent them progressing? The answer is in many cases, yes, we can. The long-term remission or even cures are possible in cancer. That's true in diabetes. We know now, for example, after marked severe diet, shall we say, described by my friend Roy Taylor in Newcastle, the liquid diet for those who are overweight with diabetes, you can reverse type 2 early on. We're even finding improvements and potential cures for type 1 diabetes with immune therapy in the pre-diabetes period when with those with, for example, positive antibodies. In cancer, increased public awareness has been effective. Fear arousal. Why do people, for example, go and have a scan or a prostate PSA test or a mammogram? They go because they're frightened of cancer. So perhaps we need to raise the profile of diabetes as something that could be serious, but can be prevented on an optimistic note. We don't want to frighten people. There's no doubt in cancer that fear arousal has been very effective in raising large sums of money for research. So let me give you an example of two case histories. Case history one, a male in his 60s, routine screening, found to have a high PSA, no symptoms. Transperineal biopsy, found to have prostate cancer. Bone scan, clear, no metastases. The treatment, hormonal therapy, followed by brachytherapy, followed by external radiotherapy, and the outlook is cure. Now, I can tell you that was me. 4.5 years ago, routine PSA, very high. Always repeat a test, still high. So I went through all this, but what did my colleagues say? Medical colleagues. Oh my God, that's terrible. Can we help? You've got cancer. But, I'm fine. No treatment now. Cure. Well, that's the response. Now, this could have been me, male in his 60s, no symptoms, routine test, glycosuria. Further tests, diagnosis type 2 diabetes, yes. On examination, perhaps a bit of loss of feeling in the feet, a little bit of microalbuminuria. Outlook, no cure. Diabetes is treated with medications, but there's a significantly increased mortality risk and reduced life expectancy, even with these minor asymptomatic complications. But what would people say? I said, I've got type 2 diabetes. I said, oh, don't worry about that. My grandmother had it. She was 90. She was fine. She lived till 90. Just a touch of sugar. Not true. The outlook for someone like this is not as good as the outlook for someone with non-metastatic prostate cancer. So we need to remember that. Here's a case history of a patient with diabetes writing in our major newspaper on a Sunday, the Sunday Times, 3 years ago. He wrote this: cancer is serious. I knew that heart disease is also serious, but diabetes did not feel serious at all to me, and now I only have one leg. His outlook, if you've had an amputation, is not good. So you could say that the key to the management of diabetes in the 21st century, first of all, can we prevent it? We can in many cases by screening. Blood sugar control. This should be up-to-date, accessible, and consistent. Diabetes complications are silent until it's often too late. Neuropathy can be silent until the patient has a foot ulcer. Retinopathy until they have a retinal hemorrhage. The evidence that screening, or if you like, secondary prevention, this is you've got diabetes, let's prevent the complications, in retinopathy is work. The National Health Service in the UK brought in a retinal screening program where everybody on the register, NHS, National Health Service register with diabetes, gets a letter every year, come to the optician, the optometrist, and have a retinal photograph. Then if there's anything abnormal or worrying, they're sent straight to ophthalmology. Diabetes was, before this, the commonest cause of blindness in working age adults in UK. Now it is not. The evidence of prevention, and it's also true for screening the urine for microalbuminuria and intervening early. So complications are potentially preventable. So how can we prevent? Who should we screen? Well, just as in cancer, if you've got a strong family history. So you've got a strong family history of diabetes. If you're obese, but how do we define obesity? In Europe, it's a BMI greater than 30. In India, it should be lower, perhaps in Indian subcontinent, because of different distribution of body fat. So we need to look again at what should be the normal for obesity. Well, obesity is never normal, but the normal definition. What's the normal in the UK? Less than 25, normal, 25 to 30 overweight, greater than 30 obese, but they probably should be lower for certain ethnic groups. So certain ethnic groups have a higher risk. In the UK, our Indian subcontinent population has a much higher risk. In the part of Manchester where I hold one of my diabetes complications clinic, there's a high Indian subcontinent population, and then 1 in 5 has diabetes, 1 in 5. So ethnic groups, history of gestational diabetes, if you're on medications, obviously steroids is one example, urban sedentary workers or other chronic diseases. So we can really select people who would be suitable for screening, and we can prevent it. Nothing is new in medicine. This is nearly 30 years old. This was, of course, from Jaakko Toimelito, our good friend, formerly a professor in Helsinki in Finland. And he had the diabetes prevention program where he randomized people with pre-diabetes or IGT to a weight reduction in this intervention group. They had 3-day diaries. They had their dietitian would speak to them. They did regular exercise. You don't have to flog yourself in a gym, although they were given free of charge access to a gym. Walking 45 minutes a day is good enough. The control group, randomized to one or the other, had general advice about healthy eating, a leaflet that we previously used. Look at the impact of this, a risk reduction of going on to develop diabetes was 58% reduced. Now, just after that, there was the American study, the Diabetes Prevention Program, DPP. And again, if you lived in New York, you didn't have to go to a gym every day. Walking 45 minutes in Central Park, for example, would be sufficient. So this sensible eating, high fiber diet, look at the reduction, exactly the same as in Finland with a different population. So there is no doubt that prevention is possible. And then, of course, we have a lot of glucose-lowering therapies for type 2 diabetes. These, my first diabetic clinic was in 1977. We had insulin, sulfonylureas, and metformin. That was it. And insulin was mainly soluble or isophane, and lente or ultra lente. PZI, you might remember, PZI if you're American, protamine zinc insulin. But this is a long time ago. Then, of course, we've had newer drugs, but most recently, in the last 20 years, DPP-4 inhibitors, GLP-1 receptor agonists, and of course, the SGLT2 inhibitors. These have changed the outlook for type 2 diabetes, such that our cardiologists and nephrologists are trying to steal our drugs. They're trying to say that they're their drugs. Remember who actually started using these. And of course, we know the SGLT2 inhibitors may be extremely effective in reducing nephropathy, and also the GLP-1 and the SGLT2s in prolonging life, less mortality from cardiovascular outcomes. One of my last jobs as president of EASD was to chair the EMPA-REG Symposium. The results were quite remarkable. This was 2015 in Stockholm. Many of you were there. The results were almost incomprehensible, unbelievable. We've all been used to cardiovascular outcome trials, but we've never seen this. It's the first time I've ever heard spontaneous applause when the results showed increased life expectancy on these agents. So there has been a revolution in the last 10 years. Now, just as a side, Burwell wrote a textbook of medicine from Harvard Medical School in 1944. He said, half of what we're going to teach our medical students is wrong and half is right. The trouble is, we don't know which is which. So if you think about it, my first diabetic clinic, the drive was to stop glycosuria. We used glucose testing in the urine to monitor diabetes, and we wanted it to be, if those of the older ones amongst you will remember the Clini test, we wanted it to be blue, which means no glycosuria, not orange, which means heavy glycosuria. What do we do now? We give drugs that cause glycosuria, absolutely opposite of what I was taught in medical school. So this may well be true. And if you think about it also in diets, when I first diabetic clinic, we gave a low carbohydrate, average protein, average fat diet. Now we give a high carbohydrate, low fat, average protein diet. So there's always never too late to learn. There's always something new. As Charlie Chan would say, it's never too late to learn, but it's sometimes too early. Now here's immunotherapy to prevent type 1 diabetes. Here's a study presented at the ADA meeting last year, and the FDA later on in the year. And this is immunotherapy. And it prevented demonstration that you could preserve beta cell function, leading to the delay of onset and potentially, in some patients, the prevention of clinical type 1 diabetes. This is using immunotherapy. So there is hope in terms of potential prevention for type 1 and type 2 diabetes. Now, of course, last year, it was a centenary of the discovery of insulin in Toronto, Canada, by Banting, Best, Collip, and MacLeod in 1921. And the first dog was successfully treated, apparently called Marjorie, by the way, with insulin in November 1921 in Canada. The first successful injection of insulin into a human, Leonard Thompson, was 100 years ago this year. But diabetes is not 100 years old. It's a long story. And of course, speaking in Egypt, one has to mention that one of the first descriptions was from Egypt. This is the Ebers papyrus, a long time ago. Now, Ebers was a German Egyptologist, but he discovered these, but of course it was described in India, glycosuria. In India, the first documented tests for honey in the urine, and they demonstrated that flies and ants were attracted to urine. I'm not sure that's a great clinical sign today. But of course, it was 100 years ago that we had the successful discovery by Banting, who was remarkably an orthopedic surgeon. So it shows you do have bright orthopedic surgeons. But he saw the light and went into diabetes, and Best was a medical student. I always tell my students, there is hope for you, because Charles Best, who got the Nobel Prize with Banting for the development of insulin, was a medical student. And if you're interested in medical history, so was Paul Langerhans. The islets of Langerhans were described by Langerhans as a medical student in a small thesis. And sadly, he died very young of tuberculosis. And one of my first jobs as the first meeting as president of European Association for the Study of Diabetes was to unveil a plaque at the University of Berlin to Langerhans. Later that year, I spoke at the Portuguese meeting in Madeira and was taken to the British cemetery there, where just aged in his 30s, he'd gone there to a sanatorium for fresh air before, of course, any antibiotics were available for tuberculosis. And he died, and he's buried in the British cemetery, which is very sad. He died so young. So we're interested in the IDF to talk about access to diabetes care, access. Now, of course, last year we were celebrating the discovery of insulin, but it's not just discovery. It's really, we need to ensure as a global diabetes community that everybody has access to insulin or the drugs they need for diabetes, whether it's insulin or other injectables or oral therapies. So early accurate diagnosis of diabetes is essential, especially in type 1, obviously. And we need uninterrupted access to insulin. We need a delivery system. We need monitoring. We need lifelong education and support. And if we look at the last 100 years of history, there's been rapid evolution in the last 2 or 3 decades. Here we have the discovery of insulin. All that was available initially was regular or soluble insulin. Then the addition of zinc to insulin was 1936. We had protein zinc, PZI. In 1936. In the 1950s, we developed MPH, beef high concentration U500 insulin, semi-lente, lente, ultra-lente. Then in the 1970s, we began to get newer insulin, U100 insulins. The 1980s, semi-synthetic, and then human insulin. Then we had the ultra-long-acting, Lantus, Levemir, etc. And then, of course, in the 1990s, we developed rapid development in the last 30 years. Look what's come here. We've got these markedly newer, longer-acting insulins, inhaled insulin, and we've got Lispro, Biosimilar, Glargine, and so on. The 2020, 2030, I don't know. Unfortunately, it's difficult to predict the future. I think it was Oscar Wilde that said prediction is difficult, especially when it concerns the future. So again, if we look at here how we delivered insulin, glass syringes. My first diabetic clinic, patients were bringing in glass syringes, boiling them, and they used them till the needle was too uncomfortable. And then we had the first blood glucose meters in the 1970s, generally available in the 1980s. And the first pens were available in the 1980s. But look at the progression now. We have smart pumps, we have Libra using smart technology. And if many of you will have seen our former Prime Minister, we seem to be going through them rather rapidly at the moment, but Theresa May in the House of Commons, you could see she had a Freestyle Libra on her arm. She had late onset type 1 diabetes. Then we've got these second generation insulin pens, smartphone data, and closing the loop. So huge progress has been made. But remember this, before the discovery of widespread availability of insulin, the diagnosis of type 1 diabetes was a death sentence. Sadly, in many parts of the world, it still is, and this is criminal. So we believe that we should place World Diabetes Day 2021 and the next 3 years, including this year, next month, in fact, 4 weeks from today when I'm recording this lecture, there's the 14th of November is World Diabetes Day. So we have a 3-year theme to promote access to all essential diabetes medicines, technologies, and education. Affordable and quality management should be available to all, whatever race, wherever they live. So to end, I'm going to tell you what we've been doing for crises. Sadly, there are crises across the world right now. We've recently had the terrible flooding in Pakistan. But everybody is talking today about war. I never thought I would see war in Europe, but sadly it is now happening. The illegal invasion of a sovereign independent state by Russia. So we work with Direct Relief, an IDF member and partner based in California, to help deliver areas of crises, including war zones. And we have one of my vice presidents, Irina Vlasenko, is in Kiev, and we've been in regular contact with her. And we've been working throughout the last 7 months to ensure that all medications are getting there. And good news is that they are, obviously not necessarily to the Luhansk region, which is being bombarded right now. Let's pray for an end to this really appalling aggression. As I say, the flooding in Pakistan. But also, many of you will not know that just south of North Africa, you have Ethiopia. The Ethiopian government, together with the Eritreans and Somalis, they're putting a blockade on the Tigray region of that country. They are blocking drugs to keep people alive entering. 2 weeks ago, I was on BBC World Newsday talking about this. Basically, it's a war crime. They're bombarding the country and blocking medicines, food. People are dying. I've had stories of people going to the hospital in Mekelle to get their insulin, having none, and then leaving and dying. This is the 21st century. And therefore, it's vital that we work with all our corporate partners and Direct Relief. We work with the UN, WHO in responding to crises. And this is appalling what's going on now in Tigray and in Ukraine and in Pakistan. So let me end with a few quotations. This is a Chinese quotation from many years ago, and it said, "Superior doctors prevent the disease. Mediocre doctors treat the disease before it is evident, whereas inferior doctors treat the full-blown disease." Sadly, we're sort of migrating from being inferior to mediocre. But we need really to move forward in diabetes to prevention, primary prevention, identifying high-risk groups, type 1 with necessary antibody tests and so on, and type 2, the groups I've suggested. We know we can prevent the onset. And here is Gandhi. One of his favorite quotations was this: "He who strives never perishes." So it behoves us all, as diabetologists, healthcare professionals looking after diabetes, really to strive to try and prevent diabetes primarily. If we can't prevent it, let's have secondary prevention, prevent the complications. If the patient's already got complications, for example, if you've got neuropathy, then we can prevent a foot ulcer from occurring with education, regular foot self-care. Tertiary, if you've had an ulcer, let's prevent the next one, and so on. Lastly, it's not going to move forward. There we are. I really look forward to seeing many of you, and please do register and come to the beautiful city of Lisbon, December this year, 2 months from now, for the World Diabetes Congress, which was postponed because of the COVID pandemic from last year. Lisbon, a beautiful city, the cheapest city in Europe, and we have Professor Jonathan Shaw, an outstanding diabetologist, epidemiologist from Melbourne, as the program chair. We've got a fantastic program, and we have discounts for registration. Do get in touch. It's never too late to register. But if you need a visa, we can help you there as well, because we've got contacts in the right places to speed up the issue of visas. So with that, I look forward to seeing many of you in Lisbon in less than 2 months from now. And I wish you a very successful and enjoyable conference in Cairo, or if you're in hybrid, wherever you might be. Shukran.